Everybody got the PowerPoint? I apologize, I uploaded it a little late last night. Try and catch up for the weekend.
I like Wi-Fi.
Alright. Those are your objectives. So let's go and start with anatomy. Okay, this should all be review. Okay. The biggest thing that we want to remember are the 3 different layers of a vessel. Okay, the innermost is the tunica intima. The middle one is the tunica media. And the outside layer of the vessel is the tunica adventitia. These are really, really important to remember when we start talking about dissections and transections and pseudoaneurysms, and it all depends on what part of the layer it actually gets through. Okay, so this is really important to remember. Okay? Alright. Again, this should all be review, think back 4 semesters. Right? Think about all the different types of vasculature that we have. So in the brain, you have to remember off the aorta, you have your brachiocephalic, okay, that goes over to the right. Then you have your left carotid, and then your axilla, or your subclavian, sorry, coming off. And then your right brachiocephalic goes up into your, breaks off into your right common carotid. The vertebral arteries are you know, especially important going up through the foramen of your cervical vertebrae. If we have a cervical spine fracture, then that's something that we need to worry about. So again, this is just for review, because in the questions for the test, I may say, you know, femoral or popliteal or axillary, so this is just review of where these arteries are. Alright, veins. Veins are a little bit different because they have valves. They still have the tunica intima, tunica media, tunica adventitia, but then we have this added addition of valves. Right? It helps with our one-way flow. When the valves become incompetent, that's when we start having like varicoceles or varicose veins. And again, just to review, just so that when I ask a question, I'm like, I won't ask questions like, where's the femoral vein, right? But if I say something about varicoceles or varicose veins or, you know, whatever, you kind of have an idea of where it is in your head. All right, and then vasculature again for the neck. This is going to be extremely important when we talk about endocrine tomorrow, when we talk about thyroidectomies. Okay. But we still want to know where all the veins are in the neck. Okay. So again, just review. All right. So what is an arterial aneurysm? It's a local dilation of an artery. There's common locations, but it could theoretically be anywhere. Thoracic, abdominal, iliac, femoral, popliteal, carotid, cerebrals, mesenteric, all of those are the more common places. But again, it can happen anywhere. Normally we assign it as an aneurysm if it's like greater than 50% of its natal vessel size. Right. So if it's 2 times its size, then we can pretty much say that it's an aneurysm. Okay. Now with an aneurysm, all 3 layers are widened. It's not a tear. There's no discontinuation of those layers. All 3 of them are just widened. Think of a balloon, right? All widened. Common causes: atherosclerosis, 95%, okay, and hypertension. All right. Now there's different forms or subtypes of aneurysms. The most common one is saccular, just a discrete outpouching of the vessel wall. Okay. You have diffuse or fusiform. That's when you have like the full abdominal aorta or aorta distal aorta going into your iliac space diffuse, versus saccular is one little area. If you see mycotic, it means it's associated with an infection. Doesn't matter what the bug is, right? It's just an association with an infection. And then we get into pseudoaneurysms, which are an incomplete transection. It's a false aneurysm. Okay? This is something that has an actual layer disruption. Most likely it's the tunica intima, okay, the innermost layer. Right? It separates, leading to this aneurysm. Right? It can happen if we puncture it, if we lacerate it. When we are doing IVs and or central lines, if we don't go all the way through all three layers, we can actually cause a pseudoaneurysm, a pseudodissection. You'll still have a distal pulse. You'll still have signs of perfusion. If it's really, really progressed and it's actually causing compression, that may be, you may not have that, but for most of them, you still will. If it's from trauma, you may actually have it like a pulsatile hematoma. And again, pseudoaneurysm, some sort of trauma is what caused it. Whether us sticking it with a vein or sticking it with an IV, central line, arterial line, okay, or if it's from actual trauma, like a MVC or something like that. Okay. Mycotic aneurysms, most common cause is staph. But again, it could be anything. It could be fungal, but staph is the most common. All right. Going into abdominal aortic aneurysms first. Elderly male. Males are 4 times as likely to be affected versus females. A lot of mechanisms. It could be structural abnormality, hemodynamic factors, hypertension, okay, or it could just be genetic. Although the #1 risk factor, preventative risk factor, is smoking. Okay, if they smoke, they're 8 times more likely to get a AAA. So, get your people to stop smoking. USGFBF does actually recommend screening, preventative screening. This is one of them. Okay, if you have a male or female age 65 to 75, and they smoke, okay, you can screen them with an abdominal ultrasound, or if they are like morbidly obese, or the ultrasound comes back and it's suboptimal, you can get a CT of the chest and pelvis with IV contrast to see if this is if it's there. The hardest thing about AAAs is that expansion rates and rupture risk is unpredictable. Okay? We just cannot predict. There's no good calculation or risk factor, or there's nothing that we can assign it that would actually say if you have this, then you're going to rupture now, right? We have no idea. It's just our body's way of compensating, and so it expands on its own rate. It may rupture, it may never rupture. Okay? It's very, very unpredictable. So this is why USGSPF have actually assigned this a screening to see if we can catch it, and then trend it to hopefully catch it before it ruptures. Okay? Because a lot of them are asymptomatic. Okay? Once you get 5 centimeters or bigger, you can actually, 80% of them you can actually feel as a pulsatile abdominal mass. If you feel it and they have extreme tenderness with it, you should probably send them to a vascular surgeon. The CT at the bottom here, everybody sees this. Okay, you have the vertebral body here, and just above it, just anterior to it, you have this nice circle. Okay, vertebral body. This guy right here, that is the abdominal aorta. That is super big. That is an aneurysm. He will most likely go to surgery. Okay, that's That's very, very big. All right. So what happens when it ruptures? What does the patient come in with? Severe flank pain, back pain, abdominal pain? Okay. If it's acutely rupturing, you may have that tearing or ripping sensation. Maybe tender tip palpation. They'll have that Gray Turner sign, that flank ecchymosis. They might actually be hypotensive because they're now hemorrhaging into their belly. Right, decreased femoral pulses. Right, if your aorta is no longer supplying blood to your legs, right, you can imagine that your pulses in your femorals are going to be diminished and or absent. And then on this CT, okay, you have your abdominal aorta here. You have a little bit of calcification around it. And then all of this lighter stuff that's the same color as the fluid inside the aorta, that's contrast. Okay, so that is a ruptured abdominal aortic aneurysm. Okay, everybody see that? So this calls for immediate surgery. Okay. All right. In a patient with a leaking abdominal aortic aneurysm, which of the following is most likely found on distal exam? What do you think? 1? 2? 3? 4? You're going to have that flank ecchymosis. Okay. Absolutely. Alright. So, diagnosis. Plain films, we can sometimes see it if it's calcified. If it's calcified. If it's not, then we may not see it. Okay? You can actually see it on this first one, this tiny, you see this small layer, thin layer of white next to the spine. Okay, that's calcification of the aorta. Ultrasound is what we do first, most appropriate initial test, okay. And then we use ultrasound to follow it when we do our routine follow-ups, okay, every 3 to 6 months. Or every year, depending on how big it is initially. When we get to the point, either if the ultrasound is suboptimal, like we talked about before, or we want more detail, or if we know we're going to go to surgery, they have to get a CT angiogram, okay, of the abdomen pelvis. That's with contrast. The contrast still goes into the vein, but it is delayed so that we actually get it as it comes back around through the arterial system. Okay, so it's not contrast in the artery, that's not an angiogram. CTA is just contrast through the vein, and then it's delayed imaging so that we pick up that contrast as it goes through the arterial system. Okay. And then conventional, if we have IR or a vascular surgeon, they can do a arteriogram, okay, or angiography. To do, but if they're going to do one of those, they're most likely in the IR suite, and most likely about to go to surgery. Okay. So ultrasound, then CT. All right. So even though we can't predict it, we have noticed that if the size is greater than 5.5 and it expands more than 0.5 in 6 months, if you're female, if it's saccular versus fusiform or diffuse, okay, if you smoke, if you have hypertension, if you have COPD, steroid use, or a family history of a AAA, you're at increased risk of rupture. So if you're asymptomatic, if your patient is asymptomatic and the aneurysm is greater than 5.5 centimeters, we are going to do an elective, okay? You send them to a routine vascular surgeon consult, and they're going to do an elective repair. Now, if it is symptomatic, it is pain, it is ripping or tenderness, or the Gray Turner sign, right? Automatic, don't pass go, don't collect your $500, you go straight to the OR. Symptomatic means that something is about to rupture. And then the other one is rapid expansion, greater than 1 centimeter a year. Okay. If it is asymptomatic, you send to a consult for general surgery and or vascular surgery if you have it. If it is symptomatic, they go straight for an emergent consult with a vascular and or general surgeon. I would remember that. Those 3 timelines, I would remember those. Ooh. Up there. All right, so how are we going to treat it? There's a couple different ways we have to treat it. The historic classic way is an open. They go kind of like an X-lap. Okay, they go in and they look at, they actually open up the aorta. They stent it from the inside, and then they close it back up. Not routinely done anymore because we have endovascular stenting now, and so we can do an EVAR, which is the endovascular arterial repair. This is done by either a vascular surgeon or a IR who specializes in vascular. Most likely it's going to be a vascular surgeon. Right? They go through the arterial system and they deploy a stent. So basically it starts above the start of the aneurysm and then goes down further past it. Okay. Basically what that's doing is it's forcing the blood to go through the stent and not into the aneurysm itself. The blood that is left over on the outside of the stent will calcify and dissipate over time. The only problems with this is if it is diffuse or fusiform, right, and it goes up higher than the radial arteries, EVARs are very hard to do because if you block off your radial or your renals, then your kidneys will die. Okay, so it depends on how much is actually a part of that aneurysm. It will depend on what they can actually do. Okay. But this is pretty cool. You get to see this done. If you're not doing it, it's kind of boring, like after you've seen it once, but at least try to see it once. Okay. All right, for the first 4 hours, following an aortobifemoral bypass. So what is that? Basically, they went from the, basically bypassed from the aorta to the femorals. Okay. A 68-year-old male has total urine output of 30. Which of the following is the best next step in management? What do you want to do? Think back to our peri-op lecture for block 1. If you have someone who's dropping down their urine output after surgery, which this is a long surgery, what do you want to do? Bolus. Right? The #1 cause of urine output after a surgery is most likely hypotension, so we try to give a bolus. Make sense? Okay. Anybody not understand that? Cool. Alright. So, complications, right? So if we are putting in a foreign object into our aorta, right, infection is the #1 complication. It's still rare, but it can happen. So a mitotic aneurysm can then form either distally or around the stent itself. Right. Fistulas, right? If it's touching another surface, it has the ability to adhere and make a connection. So if you have communication with the aorta to IVC, you're going to have a mismatch of the venous arterial system, and you're going to put pressure on your heart and cause congestive heart failure. If it connects and forms a fistula within any part of your GI tract, you can actually have blood seeping in from your aorta to your GI tract, so an arterial enteric fistula, GI bleeding, they can become septic very, very fast, okay? You don't want your GI tract anywhere near a vasculature structure. Fecal material, all that bacteria, potentially leaking into your arterial system, not good, right? So if you have a patient who shows up to your clinic and or most likely the ER, asking about any recent surgeries, okay? They're sick, fever, you know, bleeding, GI bleeds, you have to ask about a recent abdominal surgery, okay, or recent aortic surgery. Okay. Another common one is blue toe syndrome, distal embolization. So we are, you know, when we do these procedures, we can knock off, you know, some plaques or some thrombi and cause emboli distally. Okay, it's showers emboli. Not a, we can't prevent it 100% of the time. So distal embolization to the toes is common. Okay, they're going to be on heparin and or an anticoagulation for a very long time. So we just watch this to make sure that it doesn't get worse. Okay, the biggest thing is making sure that it doesn't cause any what we call distal limb ischemia. So we watch this very, very closely to make sure that it starts to dissolve and get better. Okay. If it doesn't, then your vascular surgeon can then go back in and try to do an embolectomy if it's in a bigger vessel. Okay. If it's smaller vessels, it's harder to do, but it's something that we can do if this becomes an issue. All right, we have a 65-year-old male found having an asymptomatic 6 centimeter abdominal aortic aneurysm on CT angiogram. It has grown 0.2 centimeters in the last year. Which of the following is the best option for this treatment, or for the treatment of this patient? Who wants 1, 2, 3, 4, 2, right? So it's asymptomatic and it's greater than 5.5. You elected. What if it was symptomatic? 3, right? You're going to go straight to emergency. Okay? Alright. Now let's switch up to thoracic. Possible etiologies of thoracic aortic aneurysms. So you can have aortic dissections. So there's a disruption within one of the layers of your aorta, causing a dissection. Okay, Marfan syndrome, connective tissue disorders, infection, trauma is the most likely cause. It's associated with but not caused by atherosclerosis, unlike the abdominal aorta. Okay. Doesn't help it. It's just associated with it. It doesn't necessarily increase risk. Alright, so what is a dissection? A tear in the vessel wall that does not go all the way through. It creates a false lumen. An acute aortic dissection within the thoracic, well, within any region, okay, whether it's aorta or abdominal aorta or thoracic aorta, it is a very catastrophic event, okay? Because it can really, really cause bad things, we try to get these people to the hospital as soon as possible. Those are just some other ways. So if you have brittle aortic wall, so if you have a really old lady or old man and it's really calcified, okay, any little thing could potentially cause it to break. There you go. We already went through. All right. So classifications. There are 2 main classifications that we go by, either DeBakey or Stanford classifications. DeBakey 1 is very, very proximal. It is the aortic root. This is what is attached to your heart. 2 is a little bit further up. Okay, it may include the root, but it includes part of the arch. Oh, I'm sorry. I got that backwards. Take that back. Rewind. Sorry. DeBakey 1 is diffuse. Okay? That's why it's the most likely. It includes the root all the way down. I apologize. Okay? Versus a DeBakey 2 is just the root. Okay. Everybody see that? I'm sorry for messing up. Okay? So DeBakey 1 goes all the way down, it's diffuse. Okay? DeBakey 2 just includes the root. But if you're, so 1 and 2 is a Stanford A. Okay? And if you have either DeBakey 1 or DeBakey 2, you're at a very high likelihood of rupture. Okay? Versus a DeBakey 3 or a Stanford B is basically any rupture past the arch. Okay? It's distal. Okay? DeBakey 1 is actually the most common. Alright, so, dissections. Okay. Men over the age of 60, it is common, or that's where we're going to see it more often. They're going to have sharp, sudden, tearing chest pain or back pain. History of hypertension is very, very likely in more than 70% of patients. If they have prior cardiac surgery pre-existing aortic aneurysms, and if they do crack cocaine and or weight lift, they're at a higher predisposition for this to happen.
What about that?
Right? Get people off crack. Okay? Okay, so going down family history, why is it important to know your family history? Right? 19% of people who have a family history of this are at risk of an aortic dissection. What are you going to look for? You're going to look for pulse differences between the arms. Okay, if you look back here, right, you have your subclavian and your brachiocephalic, right? If it is up to that point, or if it's just part of it, you may have a pulse difference. So it's very, very important to feel those pulses within both arms. You may see or hear a diastolic murmur, meaning acute aortic regurgitation because of the backflow problem. You may have pulmonary edema. And then if it has actually involved the carotids, you may need to look for signs of a stroke, okay, or a cerebral vascular accident. How do we diagnose it? First off, because it's tearing, ripping chest pain, we have to do an EKG. We have to rule out an MI. We have to rule out a PE first. Okay. That is very easily done. And then we do a chest X-ray while we're waiting for CT. We do a chest X-ray. What are we looking for? Widened mediastinum. Okay. We're looking for pulmonary edema. We're looking for that pleural effusions, but really we want to look for that widened mediastinum. Okay. If you have someone who comes in with this horrific chest pain and their chest X-ray is completely normal with a not widened mediastinum, right? There's no pulmonary edema, no pleural effusion. Most likely it's not a thoracic dissection. Okay? You really have to have that mediastinal widening to show that you're going to have that. And then if you don't have that mediastinal widening, but you are like, this really is screaming thoracic dissection, then you can go to CT. Okay? You can either do CT chest with IV contrast or a CT angiogram. That is the gold standard for imaging. And then a TEE, so transesophageal echocardiogram. Okay? One, they have to be stable enough to actually be put to sleep into twilight. This is a EGD, right, with an echo or with an ultrasound going through their esophagus looking at their aorta. You could still also get a TTE, a transthoracic echo, but to really try to find that intimal tear, you want to do a transesophageal echo. Okay. All right, so I would know these three things. If you have a patient with abrupt onset of tearing chest, back, or abdomen pain, pulse deficit or BP difference within each arm of greater than 40 millimeters of mercury, and a widened mediastinum on the chest x-ray, 96% chance they have a thoracic aortic dissection. Okay. All right. So, thoracic aortic dissections are pretty morbid. Okay. If left untreated, within 2 weeks, 75% of patients will die. Our bodies just cannot handle it. Okay. If we treat it, we drop that mortality rate down to 27%. If they are in a hypertensive emergency or hypertensive crisis, or even if their blood pressure is even slightly elevated, we will put them on a beta blocker, most likely IV esmolol, and then a vasodilator to try to bring down the pressure that's in the aorta, hopefully mitigating that risk of rupture. Okay, if we lower the blood pressure in the aorta, hopefully we can mitigate this to slow down that process of an acute dissection. Okay, and hopefully give us enough time that we can make it to the OR. Anything that's ascending, okay, meaning from the root up, is an emergent surgical management. Okay, we have to take them to the OR, but we will still do beta blockers first. We will start a beta blocker and get their blood pressure down pretty low while we're setting up the OR. Okay, we can't go to the OR if their blood pressure is 200. We can't. They will not survive the surgery. So we have to get that blood pressure down before we go. Okay. If it is a descending, so a DeBakey 2 or a DeBakey 3 and Stanford B. Okay. If it's the descending one, we can normally manage that medically. Okay, keeping their hypertension under control, giving a beta blocker, and anticoagulation. Okay. All right. 65-year-old male presents to the emergency department complaining of acute onset of pain that started in the anterior chest. He says the pain is excruciating and now radiates between the scapula. Respiratory rate is 22, pulse is 120, blood pressure is 80/55. Physical exam is significant for a diastolic decrescendo murmur heard along the right sternal border, which the following is most likely diagnosis.
2.
2 on 1, 2, 3, 4, 5th. Good. Yep. Aortic dissection. Okay. Now, are you going to put them on a antihypertensive?
No.
Are you going to put them on a beta blocker?
No.
Yes. Still want esmolol. Still going to put them on a beta blocker. Still going to, we have to drop that blood pressure down. Or not the blood pressure, the heart rate down. Okay? We are still emergently taking them to the OR. Okay, but we still want to put them on esmolol. Yes?
Would that be like in combination with saline or something, since their blood pressure looks like it's so low at this moment?
Wouldn't that beta blocker still lower the blood pressure more?
Not as much. Esmolol is a, it doesn't affect the, I mean it, well, I'll do that. Esmolol normally is, if I'm remembering correctly, is a, I think it's a beta agonist where it just does the heart rate.
If you
I'll
drop the heart rate,
I'll
you're
get
gonna
back.
drop the blood pressure.
What's that?
If you drop the heart rate, you're gonna drop the pressure.
Right, we're going to the OR. Right? We still want certain things. Okay. But I'll get back to you. I will, you got me on that one. I will look that up for you and I'll have it before before our next, when we come back. But either way, it's still the aortic dissection, guys. Okay, we're still gonna go to the OR. Alright, let's talk a little bit about blunt thoracic injury. Okay, blunt aortic injury. Okay, this is from a rapid deceleration injury of the aorta. You see this most with car crashes. Okay, hitting that steering wheel, motorcycle crashes, and fall from a great height. This is more than 3 stories, 30 feet. Normally it's going to be distal to the subclavian artery. Okay, so it's going to be lower. It's going to be that DeBakey 3 or Stanford V. Okay, and that's due to where that ligamentum arteriosum attaches to the aorta. Okay, it's that fetal remnant. All right. We don't see this too much in the hospital because a lot of people, if they have a true, full-on dissection or transection, most die at the scene. Okay, this is a pretty catastrophic injury. If that patient's outside layer of their aorta, the adventitia or the media can hold. Okay, if they can hold on until we can get to surgery, then we see what we will see when we talked about the just a normal thoracic dissection. Okay, but most of the time, if you have that much force, it's most likely going to go all the way through, which is why we don't see them too much in the hospital because they're dead on scene. So yeah, complete tear, laceration of the aortic wall equals transection equals high likelihood of death. Very unlikely that they'll get to us in time. Okay. So for these, we're still going to do a chest x-ray, but we really want to try to do a CT if we can. Okay, CTA, this is the most reliable test. Really want to, unfortunately, delay repair. Okay, we really want to have very tight control if we can, right? If they get to us and they're still alive, that means their outside layer of their vessel is going to hold for a little bit. We want to get really strict blood pressure control, really strict heart rate control, trying to really get their hemodynamically stable, and then we'll go to surgery for repair if we can get them. Because we really want to decrease those forces preoperatively with that beta blocker. Okay. We can do open repair or we can do that EVAR, like we talked about before. Okay. It just depends on where it is in the artery. But since it's lower down, we can do both. Okay. All right. When a transesophageal echocardiogram is done to diagnose an aortic dissection, what is the critical finding that leads to a diagnosis? When you're doing a TEE, what are you looking for?
Slow flap.
Intimal flap. All right. Everybody understand that? Cute. All right. Do a few more, then we'll take a break. All right, mesenteric ischemia. This is an occlusion of your mesenteric vessels. Most likely caused from atherosclerotic disease. It could have started there, or it could have flown there by an embolism. Okay, you may have venous outflow thrombosis, or if you were in a low flow state, like hypovolemia. Okay, it's non-occlusive, but we're not giving enough blood to our bowels, therefore, mesenteric ischemia. Okay. We do normally see this in a patient with who's a cardiopath or a vasculopath, like we say. Okay, if they have severe coronary artery disease or peripheral vascular disease, okay? Mainly peripheral arterial disease, PAD. Okay. That's when we see these. You're gonna have severe diffuse abdominal pain. Okay, they're gonna tell you they're in pain, 10 out of 10, 12 out of 10 pain. But when you actually do your exam, they're really not tender, they're really not guarding. They may have that doughy belly that we talked about earlier. Okay. The pain is way out of proportion. You do their belly exam and it's pretty normal. You're like, well, I don't understand why you have 12 out of 10 pain. Okay? If that is that clinical picture that you're, starting to develop, you should already be thinking of mesenteric ischemia as a possibility. Right? If it's chronic, we see a lot of food fear. You have these little cachectic people, your vasculopaths, and they just don't want to eat because every time they eat, they have belly pain. It increases their pain. Every time they try to make their belly work, it increases their pain. Okay? So they don't want to eat. They have weight loss. They may have diarrhea, nausea, and vomiting. We look for it on a CTA, other abdomen pelvis, or an arteriogram with IR or vascular. How we fix it is percutaneous transluminal angioplasty. I've yet to actually see this. I bet it'd be really cool. But basically, vascular and or IR is going in and trying to find that vessel that is occluded, and then either stenting it or doing an embolectomy. Most likely stenting. Okay? That's if it's occlusive. If it's not occlusive, we try to fix the hypovolemia state that they're in. Alright. So it's mesenteric ischemia. That could be any small or large bowel. Now, when we just talked about specifically the large bowel, the colonic ischemia, okay, it's hypoperfusion of the large intestine. Think back to our last block, where you remember that watershed between SMA and IMA, superior mesenteric artery and inferior mesenteric arteries. If either one of those are taken out, a large portion of your colon may be taken out as well. So hypovolemia and hypotension are big ones. We see this a lot with aortic bypass surgery. Okay. If they bleed, if they are in any sort of severe hemorrhagic shock, they are at risk for ischemia of their bowel. Okay. You may have hematochezia, diarrhea, abdominal pain, and fever. Abdominal X-ray, not going to really show much. We can potentially see it with CT abdomen pelvis with IV contrast. Okay. It's just going to be non-specific findings though, right? It's not normally occlusive. It's from a low flow state. So imaging, although CT is most preferred, it's really trying to rule out everything else. Endoscopy, we try to avoid it, but we can do it cautiously if they're really confident in their skills, to just make sure that there's nothing going on internally. But for this one, it's really just supportive care. Okay, we try to get them over that hypovolemia, over that low flow state. Okay, we're giving them IV fluids, bowel rest, antibiotics. If the colon dies though, right, if you have an actual infarction and necrosis within your bowel, you have to resect it. So we try to get to it before it resects, or before it is ischemic and then perforates. Okay. Let's take that. We had the lunch and learn at noon today. When we're done over in the junior classroom, you can meet some other surgical PAs within the Navy and the Army. The Air Force couldn't make it, but I have the contact information for any Air Force people who want to talk to a surgical PA. Yeah, so let's get to that. Let's get to some fun, okay? So, it is a selective beta blocker. Really only affects the heart. Okay, so esmolol will bring that heart rate down Normally we want it lower, like 60. So 120 is way too high for them to successfully get through surgery. We're still giving them that bolus, right? We're still trying to support their blood pressure, but trying to lower that heart rate. So it doesn't have as much effect on the blood pressure as it does heart rate, which is why we give antihypertensives and beta blockers and Esmolol if they're in a hypertensive crisis. Cool? I kind of know what I'm talking about. Then you guys try to trick me. All right, let's talk about cerebral vascular disease. Okay, so it starts within the carotids and it goes up. All right, many are asymptomatic. A lot of people don't know that they have this. One of the diagnoses that we see a lot with CVD is TIAs, okay, transient ischemic attacks. You may have hemiparesis, you may have slurred speech. The amaurosis fluxi, which is the loss of vision, okay, could be transient, could be permanent. This may be their first symptom. And meaning transient, right? It comes and goes. So it'll happen, they have some weird things, they may not be able to speak right. Normally it resolves after before 24 hours. The Hollenhorst plaques, okay, you can see that right there, that little white plaque, okay? Hollenhorst plaques, they are indicative of TIAs and cerebrovascular disease, or coronary artery disease. This is why we look in the eye when anybody has hypertension. Bruits are a non-specific finding. Okay, Bruits can mean a lot of different things, but if you find it, you should be thinking of carotid arterial disease. Okay, you should be either doing an ultrasound or trying to figure out what is going on. All right, 65-year-old male with hypertension, diabetes, and prior MI is found to have profound weaknesses in the left arm. Examination of his eyes reveals that he has Hollenhorst plaques. What is the most likely diagnosis?
2.
Anybody disagree with 2? You want 3? Okay, yeah, 2. Carotid artery stenosis. 2. Okay. All right, so atherosclerosis is a very common cause. There isn't much other things that cause it. Now, when we have cerebrovascular accidents, okay, or strokes, we have it from embolization, most common. Okay, you have that platelet aggregation, that plaque breaks off, travels up, and you get stroke. Okay. If you have a patient with arterial fibrillation, that platelet aggregation could have attached itself to a leaflet, to a valve, okay, broke off from that, and or it's in the atrium floating around, okay, because the atrium aren't working correctly. And so from there, that plaque or that emboli leave the atrium and then go up. Or it's flow related. Okay, you have a narrowing artery or spasmed artery, okay, or if you have a hypoperfusion, hypovolemia type effect. Anytime you have decreased brain perfusion, you can have these things. All right, diagnosis. How are we going to find carotid artery disease? Duplex ultrasound is the most useful test. Okay, duplex is not just ultrasound. You really have to have that color flow on it to really make sure the amount of blood that's going through. Okay. It can assess for luminal dimension or diameter as well as blood flow. This is where you get that, oh, it's 75% or it's 100% blocked or, you know, whatever. Okay. The next one is a CTA brain and neck. Okay, we're looking for, those are the people that we are already coming in with stroke-like symptoms, okay, we want to do a CTA of their head and neck to look for blockages. We want to look for the strokes. We're most likely going to see hemorrhagic strokes on CTs, whereas if the CT of the brain and neck come back normal, we do an MRI of the brain and neck to look for ischemic strokes. Okay? But that's the progression. We do a duplex ultrasound. Now, I will say this, unless they're actively stroking, right? We go to the CTA. If they're not, we can start with an ultrasound. Does that make sense? Right? You're not going to go through an ultrasound, duplex ultrasound, if they're actively stroking, because we want to get them that TPA or that treatment within that certain amount of time, which I believe right now is 3 hours. Okay? Sometimes Dopplers take a minute. They would have to, wait for the clinic to open up. Okay? We want to do an echo. We want to make sure that we don't have any cardiac source. Okay? We can do this by a TTE. We do this for anybody who's an AFib, valvular disease, or a recent MI. And then the gold standard to actually diagnose carotid artery disease is a carotid and cerebral angiography. Okay. It is the gold standard. Once we get to angiography, it normally means that surgery is anticipated. Okay. If we go through the ultrasound, we go through the CTA, and it's like, it looks okay. We're not necessarily going straight to surgery because it's only 25% blocked and there's no signs of TIAs or strokes, then we can go, we can hold off on the angiography. And this is really only done by neuro-IR. Vascular doesn't go past the neck. IR doesn't go past like the jaw. Okay, so we want to really do a cerebral angiogram. That's when we get neuro-IR. Okay, neurosurgery IR to do it. All right, treatment. Smoking cessation is key. We want to start them on aspirin, a little baby dose of aspirin every day. Clopidogrel or Plavix. Okay, we only really initiate that if we're pending surgery. And then we always do the serial duplex scans for trending, right? If they're 25% blocked now, every six months to a year, we reevaluate to make sure that it is not progressively getting worse. Okay? Because once we get to a certain point, that means surgery. And that's on another slide. Or that's on this slide. Okay? When you get stenosis of greater than 50% in one part or one side of your carotid, so the right side of your carotid, whatever, right or left, one side, get more than 50%, we have to go to surgery. That's too much of a blockage that we like. The bigger the blockage, the more likely you're going to start having brain issues. So historically we do a carotid endarterectomy, which is open. We block off the blood flow above and below it, above where it's blocked off. We open up the artery, we open up the carotid artery, we scrape out all that plaque, and then we close it back up. If you are a younger patient, if you have a higher rate of emboli, we can do a carotid stent, okay, which you can see in this picture here. Basically, we neuro-IR will place a wire through the middle of the clot, push out this stent that kind of like pushes all the plaque to one side, and the stent stays in place. But the patient will be on Plavix for at least 6 weeks, if not longer. All right, we have a 59-year-old with moderate hypertension. And emphysema, presents with a transient ischemic attack. Ultrasound of the carotids reveals 75% narrowing at the application. Which of the following is the most appropriate treatment recommendation? Who wants 1, 2, 3, 4, 5? Okay. Greater than 50% and already symptomatic. We're going to go angioplasty. And it's the most appropriate treatment. Everybody understand that? Alright, peripheral arterial disease is caused by atherosclerosis. It's kind of a running trend. Okay? So this is just like carotid artery disease, but everywhere else where you have an artery. Okay, it can happen anywhere. More likely it's going to be in the legs, but it can happen in the arms. Like I said, normally predominantly in the lower extremities, but it can be in the arms. Okay, and if it is, it's most likely subclavian arteries. The superficial femoral and iliac arteries are the most common location. Okay, these are older people. They have diabetes, it increases their risk. Most patients we're able to get away without having them have like chronic wounds or amputation, but in the select few that they are true vasculopaths and it gets really, really bad, they do develop these things and they do need amputations. Okay? MIs and strokes are very common in these patients because if there's plaque in one artery, there's plaque in every artery. Alright, subclavian steal syndrome. This is a narrowing of the subclavian artery. Normally for the left. Normally it causes early arm fatigue. It's a weird, it kind of gets caught underneath the clavicle and in the musculature and everything, and it's just the subclavian artery pulls blood. So you have the vertebral artery on the right will have blood come up, and then the subclavian will pull it back down through the opposite vertebral artery. Okay. Which you can kind of agree that would probably cause some lightheadedness if you're not getting all the blood that you're supposed to your brain. Okay. So arm fatigue, lightheadedness when using that arm. How do we fix it? We do percutaneous angiography or angioplasty with stent. Normally IR or vascular will do this. Okay. If we can't get a stent in because it is so compressed, we'll try either vascular graft, like that stent, okay, or bypass itself, right? Meaning we'll actually kind of like a vein, we'll take a vein and we'll flip it around so the valves are going the opposite direction to let blood flow through it. And we'll actually just bypass the area that you're having the issue on. All right. So intermittent claudication is a big problem with PAD. Okay, you have pain from ischemia, most likely with activity. The biggest thing is it resolves with rest. Okay. Either they walk to their mailbox, they walk up a flight of stairs, and they have to sit because their calves hurt so much. But then as soon as they rest, the symptoms go away. If it's within the femoral artery, okay, you have calf pain. If it's in the iliacs, you may have butt or thigh pain. And if it's if you have impotence, you may have it within the hypogastric arteries. Until you get over 40% stenosis, they're most likely asymptomatic. This is a big one, critical limb ischemia. Okay, this is that rest pain doesn't ever go away. That pain, like they sit down and that pain constantly is there, it never goes away. They're their distal extremity to wherever it is pale, it's cold, okay? It'll lead to a critical limb ischemia, and this requires emergent vascular consultation and or surgery. Okay? Okay, so what does it look like? You may see these patients in your clinic. I have. Okay? You're going to decrease or absent pedal pulses. You may have a femoral bruit. You may have a bruit within your iliacs. You'll have decreased hair and shiny, brittle skin. Muscle atrophy, impaired wound healing, so the people with chronic wounds. If you elevate their leg, it'll become very pale. If you let the foot hang down, it'll actually turn red. That's it, kind of just pulls there. And then decreased ankle brachial index. Has everybody heard ABIs? Cool. So this is nothing new. Okay, I would know how to do this. So ABI, you take your lower extremity systolic pressure, divide it by your highest brachial artery systolic pressure. Okay? You got to take the blood pressure on all four extremities. You divide however the highest number is on top. Okay, so for this one, the left arm. Okay, so when you're doing right leg, you do the leg over the arm. And then this one is, again, the other leg versus the highest arm PP. Does that make sense? Okay. So what does that mean? If an ABI is less than 1, it indicates occlusive disease. Okay. So if you have an ABI of 0.8, you most likely have a occlusive disease in that leg. Okay. If they're both 0.8, it may be higher up. How do we find it? Wherever it is, we want to do duplex ultrasound, okay? Looking for PAD. We can also do CT angiography or conventional angiography, angiogram, okay? Especially if surgery is indicated. How do we manage it? Smoking cessation is the single most important risk factor. Get your people to stop smoking, okay? We want to manage those comorbidities. We want to get their diabetes, their hypertension, their dyslipidemias optimized. We want to get them to lose weight, to exercise. That may be hard if it causes pain. Okay, if they have that intermediate claudication. And then these are the meds that you should be thinking of. If they have hyperlipidemia, putting them on a statin. Okay. Antiplatelet drugs, aspirin and or clopidogrel, okay, Thiostol or oxyphylline. I've yet to ever see these and or do these. I think they're a little bit older. And normally is aspirin and products. But you may see those if it's specifically from a vascular surgeon. Okay. You also have to think too with a statin. They may actually be causing your leg pain and leg cramping. So it's that patient conversation that you need to have. Okay, operative treatment. What are we going to do about it? Okay, there's a couple different ways we can do this. The first way we'll try is an endovascular approach. Okay, we'll go through the femoral artery. Okay, and try to do a angioplasty and or stenting within the area that is closed down. Okay. If the limb is being threatened, they're already in that critical limb ischemia. Okay. We will most likely do a bypass. Goals are we're trying to prevent that limb loss. We're trying to maintain that bipedal gait, trying to avoid disabilities. Okay, and maintain their lifestyles. And then 5% of patients who present with claudication within 5 to 10 years will require an amputation. So it's not as common, but if we cannot keep that blood vessel open and that area vascularized, then most likely within 5 to 10 years it's going to need amputation. Alright, 71-year-old female with lifestyle limiting claudication undergoes angiography. The imaging shows heavy disease burden in the arterial iliac region. She subsequently undergoes an arterial bifemoral bypass. Before closure of the skin incision, which of the following is the most important next step to manage this patient?
4.
Who wants 1, 2, 3, 4, 5? Yes. Why do you think we want to check the pulses? See, what we did worked, right? If we did all that work in the bypass and it already clotted down, well, it didn't work, right? So that way we're already in the OR suite. We can then go and try to open that vessel up and do a embolectomy, right? Or try to figure out where it's not, where the blockage is. Okay. All right. Acute arterial occlusion. This is that critical life ischemia. Okay. What are you looking for, or what causes the emboli? You have chronic peripheral vascular disease, normally peripheral arterial disease, and or traumas. We see this. I see this more so with traumas. Okay. And we'll talk about this more in our trauma block with like compartment syndrome. But these are the 6 P's. Okay. I would know these 6 P's. Alright, if you have pain out of proportion, just like when the gut is, not getting enough blood, right? You're going to be out of proportion for pain. You're going to be pallid, they're going to be pale, okay? The pilokelothermia, they're going to be cool to the touch. They may have some paresthesias, meaning that the it's so tight in there that they're actually putting compression on the nerves and causing paresthesias, okay? And pulselessness, and then paralysis. Now, I put these in order. Pain out of proportion is your first sign, okay? If you get to pulselessness or paralysis, you are too late in your diagnosis, and most likely muscle has died, and you will have permanent damage. Okay, so that is in order. We want to try to catch it when it is that pain out of proportion. Okay. Diagnosis again. No edema. This is not peripheral venous disease. Okay. They're not going to be swollen. And then any of those 6 P's that we just talked about. What are we going to do? We're going to either do an embolus. It's either for an embolus or a thrombus. So we're going to anticoagulate with heparin in the atraumatic patient. Okay. If light touch is still intact, we can try to do an arteriogram and try to do an embolectomy. Once we get to that neurologic compromise, we have to do some sort of surgical intervention. Okay, we have to try to fix that foot. We'll most likely skip imaging. We won't necessarily do any CTAs because we're going to go straight to the IR suite or the vascular suite and do angiography. Okay, so that when they find that blockage, they can immediately take it out. We're just basically skipping the donut of truth. Okay. If it is due to trauma, we try to repair and or embolize that artery. Okay, we will do a fasciotomy to prevent compartment syndrome. Okay. All right. This is a very specific injury. Normally when we have a knee dislocation, an anterior knee dislocation. Okay, you'll see here, the femur is anterior to the tibia. You can think all of that what's behind the knee is stretched. We can also see this if it is a sonic injury from a bullet. Okay, that blast pathway. Normally you have an internal disruption of the intima, which then causes thrombosis. Really no bleeding, it's all within the vessel. Okay, you may still have distal perfusion from the accessory collateral, but a lot of it we just need to optimize and urgently try to manage the ischemic injury. So doing a fasciotomy, trying to stent this, okay, reducing that knee if that's an anterior dislocation. And it doesn't necessarily have to just be arterial. I've seen this in veins. I had a gunshot wound through the leg, very close to this, and we did a CTA, and the artery was good, but then later on, he actually then developed an acute clot within the popliteal vein from that blast injury. So it could be both. All right, talking about transected arteries. Okay, you have a penetrating wound, deep lacerations, partial amputations. Okay, this is a full-on cut through an artery. Okay, you have intimal injuries, which we already talked about before. We have sleeve aneurysm, but a transection is a cut all the way through. Now, you may still have minimal bleeding. Okay, our arterial system likes to retract and clot off if they can. Okay, so it may spasm down, which is why after you put direct pressure on something, you don't take the dressing away to PEEP. You just keep putting more pressure on it until you're in an area that you can actually fix it. Okay, so our blood vessels like to clot off, they like to contract. But you will have absent distal pulses. Okay? You will have distal ischemia. This must be corrected within a few hours or the distal part will die. Okay? Alright. So, when we are looking at penetrating injuries, we want to look at like hard signs. Okay? If there's no hard signs, so if they're hemodynamically stable, there's no fractures, and no hard signs. So no severe bleeding, no expanding or pulsatile hematoma, no absent or distal pulses, diminished pulses, and there's no presence of a thrill or bruit, okay? No hard signs, we can observe. See how they do. Okay? As well as their ABI must be above 0.9. If any of these things are not met, right? If they're not hemodynamically stable, their ABI is less than 0.9, or they have any single one of these hard signs, we're going to do something. Okay? We're most likely going to do a CT angiogram, as well as a CT with IV contrast to look at the venous structures. Okay? We're going to do possibly do an arteriogram with the vascular or IR. Okay? We can do ultrasounds, not as sometimes, it really depends on how good you are at ultrasound, but if it's any of these, most likely we're going to get an ultrasound, or most likely going to get a CT angiogram and with IV contrast to really evaluate what's going on. Okay. If patients with any hard signs, so if any of these things are happening, okay, or if they have an obvious sign of a vascular injury, right? They're pulsatile bleeding, maybe you actually see pulsatile bleeding out of the wound, okay? They're most likely, or pretty much 100% of the time, taken to the operating room for exploration, okay? If it's a little arm laceration and we can actually see the vessel, we can ligate it off, they have good periphery, good collateral, and their hand is still, they still have all movements, their PMS is still intact, and we don't necessarily have to take them if we can fix it in the ER. But at any other point, if there's a very low threshold for taking it to the operating room for exploration. Okay? Alright, popliteal artery entrapment. I don't think I've ever seen this in practice. But basically it is, you have, that patient has an abnormal insertion of where that medial hepatic gastrocnemius occurs, or inserts, okay? Normally it's a medial deviation of that popliteal artery. They get ischemic with exercise. You'll have that intermittent claudication, asymptomatic at rest. The biggest thing is there's no other atherosclerotic type changes. Okay? Most of the time we just do surgery. We remove and move over that gastroc head. Okay? This may actually be ortho that does this, which is probably why I don't see it very often. But yeah, we normally just change the variant and it heals pretty well. Okay. Thrombo, oh, I practiced this one. Thromboangioitis obliterans, okay, or Berger's disease. We see this with young male smokers. These are the chain heavy smokers, okay? This is not just a pack a day. They're like a 3-4 packs a day. Very, very strong nicotine addiction. There's probably an autoimmune component, potentially, but you get a lot of superficial thrombophlebitis. Okay, they have foot claudication, excruciating ischemic pain, things like, you know, it's that showering of emboli, but like everywhere, right? All of their blood vessels are pissed off, and they are just in ischemic pain. Normally it goes away if we can get them to stop smoking. Most of the time it requires multiple amputations because they don't want to quit smoking. They're so highly addicted to it that they just don't want to stop, and then we just have to, you know, keep cutting off more. Okay, AV fistulas. This is the communication between an artery or vein. We can actually make an AV fistula for dialysis. Okay, normally in the upper arms. You will hear a thrill, so that's how you know if you have somebody with a surgical AV fistula. If you put your stethoscope over it and hear a thrill, you know that it's actually working. Okay. If it's a traumatic cause, we can have vascular go in and repair it to try to break them apart. But we do create these for hemodialysis. Okay, thoracic outlet syndrome, almost done. Thoracic outlet syndrome, okay, this is a disorder caused by abnormal compression of the arterial, venous, and neural structures at the base of the neck. Normally, they have a history of some sort of cervical trauma. They don't have to. Okay, symptoms develop in adulthood. Their neurological symptoms, so their paresthesias in their hands, okay, weakness in their hands and arms will be the first symptom, okay, and then venous, then arterial. So, if they have neuro, they're going to have upper extremity pain, paresthesias, muscular atrophy, okay, prolonged superabduction of their shoulders. They wake up. Now this is not somebody who like sleeps on their hands, like, you know, pterodactyl, right? But numbness of the hands when they wake up. Motor deafness are rare, but can indicate prolonged severe compression. Then venous, you can have thrombosis, which then causes pain and swelling of their arm. Okay, and then if it gets to arterial, can produce that stenosis within the arterial system, which causes arterial occlusion and emboli. Okay, what do we do to diagnose it? X-rays and peripheral nerve conduction studies are not really diagnostic; they won't show anything. We want to do a scalene nerve block. Okay, if we can do a scalene nerve block and it pretty much resolves their symptoms, then one, we have prognostic and therapeutic. Okay. Arteriograms of the arm may demonstrate that vascular, like you put their arm in abduction, right? And then you do an arteriogram, and if it is blocked, then it's most likely diagnostic. Okay. But that scalene nerve block is really what we want to do to try to do the therapeutic plus prognostic. Okay. Ultrasounds, MRIs, CTs, angiography can help. But really, we try to do that scaling block. Most will just need physical therapy, postural changes, changing how they sleep. If, for whatever reason, the conservative therapy fails, we can actually do a surgery of what we call a decompressive thoracic outlet, where we remove their first rib. I've yet to see this. This is one of my unicorns that I want to see at some point. So yeah, we basically go in, remove that first rib, and it allows for extra space within that upper thoracic region. Makes more room for that outlet of all the structures. Okay? If they don't want to do that, we can potentially do, arterial reconstruction, venous reconstruction with bypasses and stents if we need to. But most of the time, we can take out that first rib and they go back to normal. All right. We ended a little early. Any questions on vascular? Okay, tomorrow we're going to do